Hi everyone, thanks for listening to my presentations. Today I'll be talking about hyperthyroidism treatment. And this will form part 3 or 7 when it comes to hyperthyroidism. I have presented hyperthyroidism causes and diagnosis as part 1. And of course, hyperthyroidism signs and symptoms as part 2. And those will be very useful for you to be able to make specific diagnosis and of course, specific treatment as part 3 right now. So if you haven't listened to parts 1 and 2, please kindly do. Then you can come back and listen to this. With that, let's go. Okay, beta blockers. Beta blockers will take care of adrenergic symptoms. And that will be palpitations, tachycardia, tremor, anxiety, and heat intolerance. Thionamides. Thionamides like Methimazole, Carbimazole, and Propylthiouracil will be very useful here. Still on Thionamides. Thionamides are often studied in Graves' hyperthyroidism with the aim of making it to become Euthyroid. And Thionamides are very useful before radioiodine therapy. And even before thyroidectomy, if you apply your Thionamides, that will be very helpful. Treatment while on Thionamides could last between 3 to 8 weeks, and sometimes even more. What are the possible contraindications to Thionamides? Hypersensitivity to Thionamides is a strong factor to prevent its administration. Also, anyone with a granulocytosis should not take Thionamides. Hepatotoxicity is a strong factor to prevent its usage because on its own, it can give hepatotoxicity. And of course, in pregnancy, we can only use Propylthiouracil. I'll go into that later on. Propylthiouracil, when compared to Methimazole, will be slower. Okay? And Propylthiouracil will have more hepatotoxicity or vasculitis than Methimazole. And Propylthiouracil will have worse compliance because you give it many more times in a day compared to Methimazole that is once daily. Propylthiouracil will decrease effect on radioiodine outcome. And of course, Propylthiouracil is better in pregnancy. So even if you hate Propylthiouracil for all reasons in this world, remember, in that pregnant woman with hyperthyroidism today, Propylthiouracil is acceptable. You can use radiocontrast agent in that woman. Methimazole is not appropriate in her. You hate Propylthiouracil, right? Yeah, that's fine, but in that pregnant woman, that is the drug of choice. And it is better in life-threatening thyrotoxicosis or thyroid storm. Okay, judging by the previous slides, just before this one, now going through the characteristics of Propylthiouracil compared to Methimazole, so many endocrinologists and family physicians will choose Methimazole above Propylthiouracil, except in a pregnant woman. You can administer these medications via rectal, some with enema, intravenously or per oral. But before administering this medication, we need to have liver function test done, thyroid function test, and of course, complete blood count. You remember I've just said granulocytosis, hepatotoxicity, right? Okay, beta blockers. Beta blockers will take care of adrenergic symptoms like palpitations, tachycardia, tremor, anxiety, and of course, heat intolerance. You can use propranolol to handle this. Still on beta blockers, start early in the diagnosis and until you arrive at a complete resolution. Propranolol is a very good medication to be used here. And propranolol, besides taking care of adrenergic symptoms, if given in a high dose, around 160 milligrams daily, can actually decrease T3 concentration by up to 30 to 40%. Get that right. Somebody is saying, really? Yes. Propranolol. The reason why I will probably advocate for the use of propranolol more than the rest beta blockers in the face of hyperthyroidism is because not only that it will take care of adrenergic symptoms, it will actually help in decreasing the level of T3 by up to 30 to 40%. You can use atenolol, that is beta-1 selective. Propranolol is non-selective anyway, beta-1, beta-2 blocker. Metoprolol will also decrease T3. Sotalol or nandrolol will not decrease T3. Some countries don't even welcome sotalol anymore. But when you add all these medications with methimazole, you get a better outcome. What are the possible contraindications to beta blockers? Hypersensitivity. If anyone has a history of hypersensitivity to any of these beta blockers, don't use it. Heart block, particularly second-degree heart block and third-degree heart block, please keep it off. And if you can find your way around it, even first-degree heart block, don't use it. In the face of bradycardia, no beta blocker. Sick sinus syndrome in elderly people, because at the junction of superior vena cava and right atrium is the sinoatrial node. And the older we become, the weaker the sinoatrial node will become based on degeneration. So elderly will be prone to bradycardia because of sick sinus syndrome. So anyone with that, no beta blockers. Asthmatic patient, not all asthmatic patients will be prevented from taking beta blockers. Why that? All we need in asthma is beta 2. Okay? Any beta blockers that will not block beta 2 can be used. For example, you can use atenolol, it's beta 1 selective. You can use metoprolol, it's beta 1 selective, and so on. But those beta blockers like propranolol that is non-selective will block beta 1 and 2, and then asthmatic patient will suffer. The same in COPD, and of course anyone with severe peripheral vascular disease, don't give beta blockers. Okay, and also the renal phenomenon. In hypoglycemia, the patient might die of hypoglycemia without knowing where they are taking any of the beta blockers. And why that? The beta blockers can mask the adrenergic symptoms of hypoglycemia. Because in the face of hypoglycemia, we're going to have two types of presentation. The first presentation will be adrenergic symptoms, then neuroglycopenic symptoms. But if the individual is having hypoglycemia and taking beta blockers at the same time, the adrenergic symptoms will be masked. It won't show. And before you know it, if the glucose level is excessively low, then the individual will die right there even before knowing. Iodine treatment. A potassium iodine solution is available, formerly used for the treatment of goiter and Graves' disease. It is later considered to be dangerous. It is now having a minor role in the treatment of hyperthyroidism. Still on iodine treatment, the mechanism of action is such that it inhibits hormonal secretion within hours. It also inhibits iodine organification, thereby decreasing thyroid hormone biosynthesis, or a phenomenon known as Wolff-Charoff effect. Still on iodine treatment, we use this in thyroid storm. We use this as adjunct to Thionamides, that is Methimazole, Carbimazole, or Propylthiouracil. Also as an adjunct to radioiodine therapy, also before surgery. Still on iodine treatment, in toxic adenoma or toxic nodular goiter, iodine may actually promote hyperthyroidism. Note that, please. Iodine treatment continued. Potassium iodide solution given as 50 mg iodide per drop at 1 to 2 drops 3 times daily for about 10 days is helpful in pre-thyroidectomy, but could be 5 drops 4 times daily in thyroid storm, and it could be 3 drops twice daily for 7 days after radioiodine and 1 drop once daily in hyperthyroidism. Still on iodine treatment, potassium iodide tablets is available, and you can have Lugol solution. Lugol solution could be at 6.25 mg iodide per drop, and you can administer 5 to 7 drops 3 times daily for about 10 days before the surgery, that is pre-thyroidectomy, or 10 drops 3 times daily for thyroid storm. You can confirm all these from your pharmacist and your colleagues, please. Iodinated radiocontrast agent. It is used with Methimazole. Iodinated radiocontrast agent can also be useful in levothyroxine overdose. Apodate and apionic acid should not be used as monotherapy in patients with grave hyperthyroidism, toxic adenoma, or toxic nodular goiter. Surgery. Surgery will be required in Graves' disease with a large goiter. Surgery will be required where there is goiter causing airway obstruction. For histological and pathological studies, we could embark on surgery. Names parathyroidectomy at the same time, or moderate to severe Graves of thermopathy, you could have thyroidectomy done. Thyroidectomy could be carried out on a pregnant woman who can take thionamide, like Propylthiouracil is the only one she could take, but unfortunately for some other reasons, she can't take that. Then we embark on surgery in a pregnant woman with hyperthyroidism, but that should be in second trimester. Or in the phase of failed Thionamides, you've used your Carbimazole, Methimazole, Propylthiouracil, and it has failed, then embark on surgery. And of course, in the phase of failed radioiodine therapy, then what are we left with? Nothing but surgery. Contraindications to surgery. Pregnancy is a relative contraindication, but if you explain the associated rates, for example, spontaneous abortion or premature delivery, and the woman is still comfortable with that, then you can embark on surgery in pregnancy, but that must be at second trimester. Also, severe cardiovascular disease is a strong contraindication. Severe pulmonary disease will prevent surgery, and of course, concerns about anesthesia should give us either relative or absolute contraindication. In conclusion, radioactive iodine or radioactive therapy is the best treatment, is the best of all. In graves of thermopathy, orbital decompression will be very helpful. Eye muscle therapy will also be very helpful in Graves' disease. And with that, I've come to the end of this presentation. The next presentation will be about Graves' disease, and that will form part 4 of 7. You are still going to come across all these medications in the course of Graves' disease discussions or presentation, and of course in thyrotoxicosis or thyroid storm. Thanks for listening. Please remember to subscribe. Remember to share. I appreciate it.